Hello everyone, welcome back to the Tokyo Living Podcast. Today we're joined yet again by our resident physician, Dr Tom Lomax. Tom, welcome back to the show and thanks again for hosting me in your clinic.
Thank you for having me.
Today we're going to be talking about prostate cancer. A lot of the people listening and watching the show are sort of middle-aged foreign people living in Tokyo. So obviously the screening for things like prostate cancer does become more important. And also there has been some news of late that prostate cancer levels may be increasing in some countries outside Japan. So I thought that we would just sort of have a talk about these statistics and talk about prostate cancer in general. Yes. So perhaps if we just talk a little bit about prostate cancer, how it forms, the typical risk factors and the typical sort of demographic that might suffer this condition.
Yeah, okay. So, I mean, first of all, what is the prostate? So the prostate's a small gland about the size of a walnut when you're young, and it sits underneath your bladder. So your urethra, the tube that you pee through, goes through the centre of the prostate. As we get older, the prostate tends to grow slightly larger, which is why when you get past 50, you may find that you have slightly more difficulty passing urine, or you need to get up to pee at night. That's just your prostate naturally getting bigger with age. So as well as getting larger, as we get older, there's a certain risk of cancer forming within the prostate. So that's actually very common. Prostate cancer is really like the breast cancer of men. So for women, 1 woman in 9 in most Western countries will get breast cancer, and in the US, I think it's 1 man in 8 will be diagnosed with prostate cancer. So after skin cancers, they're the highest incidence cancers in men.
Right. And typically it's people over 50. Is it between certain age ranges? Up until
you should sort of never say never, but it's extremely rare to see prostate cancer diagnosed in men under 50. And as we get older, it gets more common. So I think the sort of the highest number of diagnoses in the UK are made in men around age 75. But you see prostate cancer getting slightly more frequent in men through their 50s and 60s and 70s. And
after diagnosis of prostate cancer, what are the sort of mortality rates and what's the typical treatment?
Yeah, so prostate cancer is an extremely mixed bag. It's definitely not one disease. So, I mean, I like to think of cancers as being like tortoises or rabbits or birds, okay? So a tortoise is a cancer that's not going anywhere. It's just sat there, it's not going to hurt anyone, and it's not going to run out of the room. You can just watch it. You don't actually need to do anything to it. A rabbit is a cancer that's kind of jumping around, and if you don't watch it, it might get away from you. But you've got a chance to catch it before it does that. And a bird, once you've seen it, it's gone. So the sort of bird cancers, the ones that we don't really have good treatments for, are things like pancreatic cancer. Now, the majority of prostate cancers are actually the turtles. They're relatively harmless. And even if you watch them for 10 or 20 years, they may not do anything, okay? But within those, there are a smaller number of ones that are potentially harmful, but that you have a window to identify and treat them, with a good chance of long-term remission. So really, the key is identifying which ones can be watched and which ones need to be treated and how.
Yeah, and how do you go about identifying that?
So I think most of us are familiar with like hearing cancers staged. Like you hear people talking about stage 1, stage 2, stage 3 and stage 4 cancer. Stage 4 is cancer that's metastasized through the body. Actually, with prostate cancer, what's more relevant is the grade. So grade is basically how abnormal the cells are. So a low grade cancer is one where the cells look slightly abnormal, but they're not changed enough to make them particularly dangerous. And if you sort of look into the literature about prostate cancer, you hear the term Gleason grade talked about. So Gleason's a way of grading prostate cancers, and the scores for that run from 6, which are the most benign cancers, through to 10, which are the most aggressive ones. Now, the Gleason grade 6 cancers can almost always just be watched. And I've got a few regular patients who've got Gleason grade 6 prostate cancer, and it's just not, we're just watching it. They have a repeat blood test every 6 months, and they might have a scan every couple of years, but that's all they need.
Okay. And what do you sort of make of the recent talk about the prostate cancer death rate?
Yeah, so I think the best evidence comes from the US. So the rate at which you look for prostate cancer makes a huge difference to the number of diagnoses and also to the death rates, but actually not in an entirely predictable way. So we've got quite a good blood test to screen people for prostate cancer. I think most of us who are over 45 or 50 will have been offered or heard about the PSA test. So that's PSA stands for prostate specific antigen. So that's a routine blood test that can quickly and easily be done in any doctor's office, get the result in 2 days. What it gives you is a number, okay? So if your PSA is less than 1, then you're basically in the clear. You've got nothing to worry about. If your PSA is very high, like let's say it's 1,000, you've got quite extensive and quite advanced prostate cancer. That's fairly easy to pick up and obvious as well. The problem with PSA testing is you get a lot of people who are in a sort of mid-range. So they'll come back with a PSA of between 4 and 10. Now, if you're in your 50s and you've got a PSA in that range, there's about a 5% chance you've got cancer.
Right.
So actually, 95% of people who come back with a high PSA don't have cancer.
Right.
The problem is identifying the ones that do have cancer often requires a biopsy, which is because your prostate's right inside you. Taking the biopsy is pretty unpleasant. I can do a whole talk about that, but you don't want to have that done casually unless there's a reasonable chance it'll turn something up.
Yes.
So the argument has always been, if you do lots and lots and lots of PSA testing, you'll end up doing a lot of biopsies, which are unpleasant and in some instances can be harmful.
Sure.
But you'll identify prostate cancer very early on.
Right.
So if you push to do a lot of PSA testing, you find lots of early stage prostate cancer. Now what that means is the diagnosed incidence of prostate cancer shoots up massively. So if you took a population, said, okay, as of this year, we're going to test everyone's PSA, you would probably find you more than doubled the rate of diagnosis of prostate cancer.
Yeah.
So we've seen that happen in the past. And when that's been done, there's sometimes been a bit of a backlash. Like a lot of these guys who've got very low grade prostate cancers probably didn't need to know about it. Cancers that aren't going anywhere, right? So maybe we shouldn't test as many people.
Right.
On the other hand, if you do a lot of testing, the small number of guys who've got the more dangerous prostate cancers, the rabbits, you do pick them up earlier on. And then you've got more opportunities to treat them and stop them from dying from prostate cancer. So in the States, when they've done more PSA testing, cancer diagnosis rates have gone up and death rates have gone down.
Right.
When they've done less PSA testing, diagnosis rates have fallen, but death rates have risen.
Yeah.
And there's a constant debate about how much we should be testing people's PSA.
Yeah. And just for the people viewing the YouTube version of this, on our previous episode with Dr. Lomax, he did do a practical example of a viral infection testing. Don't worry, we're not going to do a practical example of a prostate biopsy. So then, I guess, what are your recommendations for your patients in terms of screening and testing?
So that is very difficult to give an answer to, because I don't think there's a one-size-fits-all answer to that. I think if you are basically end of life, if you're in your 80s and you have no symptoms, you probably shouldn't be tested, because the overwhelming probability is, even if you find there's a prostate cancer in a guy over 80, he's not going to experience any ill effects. He's not going to die from it.
Yeah.
So why are you telling someone you've got cancer when actually the cancer's not, or is very unlikely to harm them?
Yeah.
On the other hand, if you're looking at guys in their 50s and 60s, there is a case for trying to identify those harmful cancers that could shave 20 years off someone's healthy life. The problem is people need to understand before they go into the process that there's this quite high chance of either ending up doing a biopsy that doesn't identify cancer and is pretty unpleasant, or of finding one of these very low-grade cancers that doesn't need to be treated but is still sort of there in the back of your mind. Like you've got a Gleason grade 6 cancer, it's probably not going to do anything bad, but you're going to have to keep doing tests and keep watching it.
Sure.
So I think probably it is reasonable for guys between 50 and 70, certainly, to have regular PSA blood tests. But there needs to be some informed discussion about what the test is, what the implications are, and what the downsides of testing are.
Yeah. Yep. It's like with any sort of diagnostic testing. It always comes with a lot of nuance and and perspective that needs to be taken into account. Right.
Yeah. So I think that's my takeaway message: is if you only do one thing, discuss with a doctor whether the PSA test is right for you.
Yeah. And so what about prostate cancer rates in Japan compared to the West?
Very low.
Really?
So there's an identifiable inter-ethnic difference in countries with sort of mixed populations. Generally, people of African ancestry have higher rates of prostate cancer, and people of East Asian ancestry have lower rates of prostate cancer, and East Asian countries have lower rates of prostate cancer. So Japan's one of the lowest.
Yeah. Any idea why that is the case?
I think that's speculative, actually. I mean, there's supposed to be a correlation with exposure to serum testosterone. Yeah. So maybe running slightly lower testosterone levels means your risk of prostate cancer is lower, but that's debated.
So in terms of treatment options, once someone has been diagnosed?
So for, as I mentioned earlier, the very low-grade cancers, they don't need to be treated, they can just be observed. And that's quite a high fraction of prostate cancers. Some prostate cancers are already spread outside of the prostate, but are still fairly slow-growing. And they can be treated with radiotherapy and also with hormone therapy. So hormones that block testosterone will often slow down or stop the growth of prostate cancers. And in guys who've been found to have a relatively high-grade aggressive prostate cancer, but one that still hasn't spread outside the prostate, then surgery is an option. And that's improved quite a lot, even during the 20 years that I've been practicing. So I actually worked for a prostate surgeon when I was a junior doctor. And I mean, he was reckoned to be one of the top prostate surgeons in the UK. But still, guys who'd had surgery with him, he would always tell them there's quite a high chance that you won't be fully continent afterwards. You'll constantly be leaking urine after you've had prostate surgery. And the majority of guys have significantly impaired erectile function. So, loss of sexual functions pretty much was the anticipated outcome of prostate surgery. Now that is still the case, but it's got a lot better with the advent of the Da Vinci robot. Okay. So now in good centres, prostate surgery, radical prostatectomy is done using the Da Vinci robot. And because that's sort of so precise, there's less associated damage to the nerves that run around the prostate. And I've had guys who've been completely continent of urine and have had relatively well-preserved sexual function after Da Vinci robot-assisted radical prostatectomy. So that's a definite improvement. And if I ever need to have prostate surgery, I would definitely be looking to find a provider who uses the Da Vinci robot and has done quite a lot of surgeries with it.
And I understand that at Tokyo Medical and Surgical, you do have one of the top urologists in the country coming in.
Yes, we do. Yes, so we're lucky enough to have Professor Horie, who's the head of urology at Juntendo, and is Japan's leading prostate surgeon, who's done the highest number of Da Vinci robot-assisted radical prostatectomies in the country. And we've referred him a number of patients and very, very happy with him. He's an excellent surgeon and he's also a great communicator.
Okay, well, that's terrific to know. So Tom, thank you very much as always for coming on, sharing your knowledge and sharing your experience with us. It's been very useful.
Thank you very much. Yeah, always a pleasure. And if there's any other topics people would like to hear about, please do let us know.
Thank you. So thanks very much for listening and watching. If you are of the age that the age demographic that Dr. Lomax mentioned before, and you would like to consult with him or Dr. Horier, then we'll put the Tokyo Medical and Surgical contacts in the show notes. Thanks very much for watching. Thanks very much for listening, and look forward to speaking with you on the next episode.
Thank you very much.